invasive APRV. Where do you choose the mode? From here. Then you go to APRV mode, then you accept. Okay, these are the settings. Regarding the FiO2, you will set it depending on your previous set of FiO2. I set it around 100 for now. Then I will go down depending on my saturation and the PO2 in the ABG. Then we will speak about the PEEP. PEEP is actually the P-low in other ventilators, but on this vent it's called PEEP. It usually should be 0, but on this ventilator we can't go down below 1, so we will keep it at 1. Then the P-high. The P-high actually is the desired plateau from 20 to 30, but I set it around 28. It plays a role in your target tidal volume. Usually it should be between 6 to 8 kg. Finally, we will talk about the T-high. The T-high plays a role in oxygenation mainly. It's actually set between 4 to 6, but I kept it around 5. I will accept. Then the T-PEEP. T-PEEP means T-low, but on this ventilator is different name. We will set it around 0.05. Sorry, 0.5. So these are the initial settings as you can see in here. Then we will start ventilation. Okay. This is the waveform. As you can see, on this ventilator, actually the APRV is a continuous lung recruitment. Okay, what is the indication of APRV? As we said, it's a continuous lung recruitment. That means mainly oxygenation. It plays a role mainly in oxygenation. It actually sometimes causes CO2 retention if you mess up your settings. Once you set your APRV mode, after 30 minutes from your settings, you have to take an ABG to make sure about your ABG, your blood gas. Also, you have to do an X-ray because it will cause lung expansion. This mode actually has shown very successful with COVID-19 patient because COVID-19 patients, they need continuous lung recruitment, which is based on APRV. For APRV management, let's say your patient is having hypoxia, what would you do? I already increased the FiO2 to 100, but your patient still is desaturated. So I will manipulate the P-high. It was set around 28. I reached into 35. Do not exceed 35. Actually it should be 30, but we can exceed into 35. And you will increase your T-high into 6, sometimes into 8, but watch out for CO2 retention, and you will decrease your T-low. Let's say I will keep it around 0.4. I will confirm. After this manipulation, you want to do an ABG, then you will assess your PaO2 for oxygenation. Let's say you have hypocapnia. What will you do? You will manipulate by increasing the T-high and decrease the P-high. But also you have to be careful about the CO2 manipulation because this APRV mode is mainly for oxygenation. Regarding the weaning, let's say your patient now, if FiO2 is below 40%, okay, now you will consider weaning. Your patient is fully awake. We will use the drop and stretch method. We will start by dropping the P-high by 1 or 2 until we reach 10. Let's assume we have already reached P-high of 10. With every P-high drop, we will increase the T-high by half, 0.5, like now, and then we will confirm. This is called stretch and drop and stretch method. Of course, you will not manipulate with the P-low, which is PEEP in here. Then after you reach these settings, you can switch into CPAP pressure support.